This video will document some of the surgical pearls that we have learned in removing a tuberculum cell meningioma through an extended endonasal endoscopic approach. We're presenting a 54-year-old woman who presented with progressive visual loss over a 6-month period of time. She had a bitemporal hemianopsia, and the MRI revealed a 2.2 centimeter extraaxial enhancing mass suggestive of a tuberculum cell meningioma. Here are the sagittal and coronal MRI scans. The tumor is clearly between the carotid arteries. It extends up to the A2 branch. The tumor lies above the pituitary gland and stalk. It extends halfway along the planum, above the sphenoid sinus, and this represents an excellent example of a case that can be and should be removed, in my opinion, through an endonasal endoscopic approach. It does not extend too far lateral, it does not extend too far anteriorly. The tumor does not reach the anterior clinoids. Although it touches the anterior communicating artery, we will be able to dissect an arachnoid plane between the tumor and the ACOM, which should not pose a problem with the proper instrumentation and the proper large opening. That opening will have to extend from the planum, midway through the planum, down into the top of the sella in order to remove the entire tumor, and from medial intercavernous medial OCR to medial OCR. The first phase of the operation, working medial to the middle turbinates, we identify the ostium of the sphenoid sinus. You can see the choana. A mushroom punch is used to enlarge the ostium of the sphenoid sinus. And then a vascularized nasoseptal flap is harvested by making superior and inferior cuts, as well as an anterior cut at the level of the middle turbinate. Here we're making the inferior cut just below the sphenopalatine artery, extending down to the floor and along the floor of the nasal cavity. This can be extended further medially if one wants to extend the width of the flap as needed, and then the cut is taken anteriorly to reach the first proximal vertical cut. Then a superior cut is made from the ostium approximately 1 centimeter below the cribriform plate, all the way to the anterior cut, and a vascularized nasoseptal flap is elevated. We're working on the patient's right side of the nose. An additional scissor cut is used to release the nasoseptal flap. This exposes the keel of the sphenoid, the rostrum, and then the cartilaginous septum is removed, approximately posterior 1/3 to 1/2 of the septum, exposing the flap on the other side. Second flap can be harvested if one wants to achieve bilateral flaps, and these can be stored in the nasopharynx. The ostia of the sphenoid sinus are enlarged on both sides, and sphenoidotomy is performed. This can be done with a kerrison or with a drill. At this stage, using a cutting burr is reasonable, although once we're removing septations, we tend to switch to a diamond burr. Here we're using the diamond burr to drill down all the septations of the sphenoid sinus, which we have to remove flat. The anterior wall of the sphenoid is opened quite extensively on either side, laterally, in order to provide enough room for us to place 2 instruments as well as an endoscope within the sphenoid sinus itself. The posterior ethmoids have to be removed. Here you can see the tuberculum cell, the planum, the left and right optic canals, bilateral medial OCRs, and carotid prominences on each side. We begin the transtuberculum approach by removing the tuberculum at the top of the sella. This is done from medial OCR to medial OCR and extending up into the planum. As you recall, the tumor extended anteriorly approximately halfway along the planum, therefore the bone must be drilled down all the way to expose the complete base of the tumor in order to achieve a gross total resection with a Simpson grade 1. The tuberculum is removed with a kerrison. The planum is removed with gentle mobilization of the egg-shelled bone. Additional drilling above the optic canal exposes the base of the tumor on either side. Care is taken not to damage the optic nerves within the canal. The dura can then be opened superiorly to expose the base of the tumor. We want to go all the way to the anterior edge of the tumor, where we can begin to roll the tumor down into the cavity, first working above the tumor. The dura is opened on either side to expose the base of the tumor. This opening is extended down to the superior intracavernous sinus. A little bit more of the sellar bone has to be removed in order to get below the diaphragma sella, and this is done with a kerrison. At this point, removing the inferior part of the medial OCR that had been inadequately removed. Bipolar is used to cauterize the superior intracavernous sinus on either side. Thrombin-soaked gel foam can be used since there can be extensive bleeding from this area. However, the complete superior intracavernous sinus and diaphragma sella must be opened medial to the carotid artery on either side in order to expose the lateral margins of the tumor. The tumor is then rolled down. There is often an excellent arachnoid plane. The tumor can be internally debulked at this point to ensure adequate visualization, and frozen and permanent sections can be sent from this relatively soft tuberculum cell meningioma. The arachnoid can be seen intact. There is fluorescein stained cerebrospinal fluid, and this is helpful to observe that the arachnoid planes are still intact, and we'll try to keep them intact for as long as possible. The tumor continues to be gently mobilized to ensure that there are no attachments posteriorly. You can see a breach in the arachnoid with some CSF leak as the tumor is further internally decompressed and then rolled down into the operative field using hand-over-hand bimanual dissection with internal decompression. We can then see the arachnoid attachments to the posterior aspect of the tumor. These can be sharply dissected if needed. The tumor is rolled in either direction to ensure that there are no attachments, and the tumor is disconnected from the dura of the tuberculum region. The optic chiasm, left A1, A2, right A1, A2, and left optic nerves can be identified. The tumor invades the medial optic canal on one side. This area is opened up. One can observe the ophthalmic artery as it extends into the medial optic canal, and tumor is rolled out. Kerrison is used to grab and remove any tail of tumor extending into the medial optic canal. Additional dura is removed along the planum in order to get the dural tail of the tumor, which is also cauterized. The lateral aspects of the dura over the carotid artery is cauterized to fulgurate the tumor, try to kill any residual microscopic cells that may be left behind. The optic chiasm is identified, which is well vascularized. The closure is performed with an onlay of fascia lata in order to achieve a gasket seal closure. This is covered with a piece of medpore which has been fashioned to be the same size as the defect, and the medpore is wedged in with care taken not to countersink the medpore to prevent pinching the optic nerves. Once it's wedged in and holding the fascia lata, we cover it with a vascularized nasoseptal flap. This has to extend beyond the limits of the fascia lata to ensure that it attaches and heals to the bone. Often 2 flaps are required, although many times we can do this with a single flap to cover the defect, and these are held in place with Duraseal glue. Post-op MRI scan reveals a gross total resection of the tumor. One can see the medpore in place, covered with a vascularized nasoseptal flap, as well as the pituitary gland stalk and chiasm, as well as medial optic canals with no tumor.